There have been very few things in the past years that have really definitively changed the way that I provide patient care. However, physician-performed bedside ultrasound has been one of those things which has really been a game changer, which has changed the way that I provide patient care. Now, with the ultrasound machine, I can actually see the pathology that I only wondered whether was there previously. Patient satisfaction has also improved. I can't tell you how many times I hear this comment, "Oh, thank you, Dr. Kuhn, for doing the ultrasound, because now we both know what's really wrong with my child." It may be counterintuitive, but actually the throughput time through the emergency department is actually shortened when the physician performs his or her own ultrasound. Oh yes, I do need to go set up the machine and plug it in and type in the patient information and obtain good images. But I may not be ordering x-rays or that CT scan or even an MRI that I might have thought was necessary without the ultrasound. And I may not be calling in consultants to see something that now I know isn't there. In a worst case scenario, I'm not doing procedures that may be unnecessary because I have a more accurate diagnosis. Well, this has really been a game changer for me. Over the next few minutes, I'd like to share with you some easy cases that really can be game changers for you too, so that you can improve your ability to make the diagnosis, you can improve patient satisfaction, and actually improve throughput time through the emergency department. So come with me now as we discuss physician-performed bedside ultrasound. Well, what do we mean by clinical or point-of-care ultrasound? What we mean by this is an ultrasound exam that is done at the patient's bedside, most often by the clinician in charge of the patient's care. We have to have enough skill to get a technically adequate exam. In other words, we need to be able to see clearly the image that we're trying to obtain, the anatomy, so that we can make an informed decision and a correct decision based on an image that is a good quality image. This exam also has to be possible within the context of a busy practice. In other words, we need to be able to get the machine in the room, set it up, do the exam, obtain the images in a minimal amount of time, and the images have to be good enough to make a decision based on those images. Now, the emergency department where I work, I'll see perhaps 30 patients a day on a slow day and 50 or more patients on a busy day. So that allows me very little time to be able to get in and do the exam and obtain the images. We also want an image that gives us a binary decision, a yes or no answer. Is the condition that we're looking for present, yes or no? We want to be able to obtain actionable information. In other words, we want to be able to get the image, look at it, and make a clinical decision based on that ultrasound image that will enhance our ability to provide patient care. What I'd like to do in the next 35 minutes or so is to present 10 cases to you where ultrasound helped in the definitive diagnosis of the patient, and it also improved patient satisfaction, as you'll see. Now, none of these cases are particularly difficult. They're all very common things that you and I see every day as we see sick children in our acute care setting. They're common enough that even after I am done recording this video, I'm going to get in my car and work a shift in our pediatric emergency department. I have no doubt this evening as I work that I'll see many of these same things that I'm going to describe to you now. So come along with me. Let's have a little bit of fun and see how clinician-performed ultrasound at the bedside can augment patient care and improve patient satisfaction. Now, let me start with a disclaimer, and that is that not everyone would manage these cases the way that I manage them, and that's okay. The object of this video is not to discuss the individual management of these cases, but to demonstrate how point-of-care ultrasound can augment the way you see these patients and shorten the duration in the emergency department, increase satisfaction, and also give you a better clinical diagnosis.
In the emergency department, a 3-year-old child presents with an area of localized pain and swelling to her left lower extremity. Parents state that there was a bug bite to the leg about 3 days ago. On exam, there is a localized area that is warm and tender and about 2 by 2 centimeters. We are unsure if it is an abscess with fluctuance, cellulitis, or inflammation from the bite. The child screams and refuses to let me examine her. The mother states that she gets frequent abscesses and has had multiple INDs in the past and is afraid of doctors. The exam is normal except for her leg. Otherwise, vital signs are normal. She has no fever. During the exam, the child acts up so much that it disturbs other children in the emergency department.
Okay, so this is our first case. What is our binary decision? Well, number one, this could certainly be cellulitis without an abscess. If it is cellulitis without an abscess, we can discharge the child on antibiotics, follow up the next 24 to 48 hours, or have the mother bring him back if they get worse. On the other hand, if it is an abscess, and it's a large one, then we're going to have to drain the abscess, and I'll probably have to sedate this child and do an I&D in the emergency department, or if it's a large abscess, we refer the children for an I&D in the operating room. So how can point of care help us in this patient? Well, it can help us by deciding whether or not there's an abscess, because that alters patient care rather dramatically. Well, this child was screaming and yelling and kicking her legs when I first went into the room, and I thought, man, I'm never going to get a good exam on this child. And I brought the ultrasound into the room, told Mom I was going to do an ultrasound, and when I fired up the ultrasound and came near her with a probe, she pushed me away and cried and screamed. Then I handed her the probe and I said, honey, why don't you do your own ultrasound exam? And I showed her how to do it. And she calmed down and did this ultrasound. And here's what we found on her own ultrasound. The majority of this area was cellulitis. There is a very small area of abscess, but it is indeed small. So we thought, oh, well, this is mainly cellulitis. The abscess is small. We really don't need to iodine it in the emergency department. We can give her antibiotics and have her follow up in 24 to 48 hours, which is what we did. Well, how did ultrasound help us in the care of this patient? We had a binary decision. Was this cellulitis or was it abscess? And it actually turned out to be mainly cellulitis with a small abscess. And it did provide for us actionable information. The abscess was small enough so that we could try to avoid an incision and drainage. We treated this patient with outpatient antibiotics and had her return for evaluation in 24 to 36 hours. Actually, the child did very well. She avoided an I&D. We avoided a procedural sedation. The parents and child were happy with me, and I was delighted not to have to sedate this child.
A 15-year-old boy was playing war with his friends. He got shot in the arm with a BB gun. He was previously a healthy child with no past medical problems. Today, his exam was all normal except for a small entrance wound in the left upper arm. Neurologically and vascularly, he was intact.
Okay, the second case. How can we use ultrasound to help us in this child with a possibly retained foreign body, or BB, in his soft tissues? Well, ultrasound can help us decide where the BB is and whether it's superficial or in a position where we might be able to remove it or not. So our binary decision is the BB there? If it is, where is it, and can we remove it? Here's the ultrasound, and we can see the BB in the soft tissues, and we see some reverberation artifact underneath it. So we can see that it's relatively superficial, maybe 1 to 1.5 centimeters below the surface of the skin. And of course, we can not only use ultrasound to see if the BB is there, but we can use ultrasound to guide our removal of the BB, as in this video. So resolution of case number 2. The BB was identified. The BB was removed using point-of-care ultrasound directed guidance without difficulty for removal of the foreign body. We avoided prolonged searching for the foreign body in soft tissues. We actually avoided getting an x-ray as well, and everyone was happy.
A 3.5-year-old male was brought into the pediatric emergency department with the onset of swelling on the left side of the neck for several hours. His father is unsure of the exact length of time. The patient was well in the morning, was playing normally, eating and drinking well. He had no significant past medical history, but now is complaining of pain in the neck and is somewhat irritable. No history of injury, does have a low-grade fever, and possibly a sore throat. On physical exam, the temperature is 38.4 degrees. The patient has a slightly reddened throat with no exudate, no evidence of scratches or injury to the hands or arms. By the way, there is no cat in the house. The patient does have a large tender mass on the left side of the neck that is very tender to palpate. It's approximately 4 by 4 centimeters by observation. During the exam, the child screams and pushes Dr. Kuhn away when he tries to palpate the neck.
So how might ultrasound help us in the care of this child? Well, our binary decision is this. If it's cervical adenitis, we can treat him with antibiotics and discharge him home to follow up with his primary care physician in a day or so. On the other hand, if it's an abscess, either of the soft tissues of the neck or of the lymph nodes, we're probably going to have to admit him for IV antibiotics or for indeed surgical drainage. Well, this was another child that really wouldn't let me get a good exam, and I admit that I never really got a good exam of his neck because he pushed me away and cried and fussed when I tried to do a physical exam. So I showed him the ultrasound probe, and I asked him if his daddy shaved in the morning. He said he did. And I said, well, just use the ultrasound probe and pretend that you're shaving like your daddy. So I handed him the ultrasound probe, and actually we got quite good images with him scanning himself. Well, considering that I never really got a good physical exam, the ultrasound actually surprised all of us. This child had neither cervical adenitis nor an abscess. What he had was a moderately enlarged, very tender salivary gland. We discharged the patient home without antibiotics, since most of these are viral. We gave him ibuprofen for fever and discomfort and a follow-up with his primary care physician. So the point-of-care ultrasound, actually at this point performed by the patient himself, avoided a CT of the neck. It avoided a surgical drainage. He was discharged home and actually did well. And as you can see, everybody was happy. Now, on the same day and just a few hours after the last patient we just saw, I had this young lady come into the emergency department. Those of you who do pediatrics know this look. That look is, you're not coming near me with your hands or that ultrasound machine. If you look carefully at the video, you'll see that there's a red area under the ear, under the jaw on this young lady. And indeed, she did have a fever, and her chief complaint was swelling under the jaw for a day or so. Her exam demonstrated that this area was extremely tender and red, and the binary decision in the differential was essentially the same as the previous child. However, unlike the other child, this ultrasound did show large matted lymph nodes under the neck, and these lymph nodes had hypoechoic areas within them which demonstrated either necrosis of the lymph node or indeed early abscess formation. So this child was given IV antibiotics in the pediatric emergency department. We admitted her to the hospital for IV antibiotics. She did well on the floor and was discharged home 2 days later, feeling quite a bit better. We avoided a CT of the neck. We avoided surgical intervention. She was discharged home well and happy, and everyone was happy with her care.
A 14-year-old slightly obese girl presents to the emergency department with 1 month duration headache. She has not had 1 day in the last month without a headache. She has not missed school. She has not taken anything for it, such as Tylenol. She looks well. There is no difference in headache intensity with lying or sitting. There has been no vomiting, photophobia, head injury, fever, flu symptoms, rhinorrhea, facial pain, or nighttime awakening. No neurological symptoms. The physical exam was normal. Neurological exam normal. Ibuprofen was given at triage. The headache moderately improved on ibuprofen.
So I know you all have children like this with a headache, and you need to think through your binary decision. Is this a benign headache? Can this child just be sent home with ibuprofen or acetaminophen and follow up with her primary care physician? Or is this indeed a worrisome headache? Is this something that we need a CT or workup on? Should we order a CT or an MRI in the emergency department? Should we get neurology to see this patient? Or should we do a lumbar puncture? Well, one other option is to do something with point-of-care ultrasound, which is to look at the optic nerve sheath to see if it's wide, meaning increased intracranial pressure. We cannot rule out other causes of worrisome headache with ultrasound, but we can rule it in with an increased intracranial pressure measurement. Ultrasound of the eye is actually quite simply done. You take a little bit of gel, you put it on a linear transducer, have the patient close their eye, and you can shoot right through the eyelid, the anterior chamber, and the vitreous, and you can nicely see the optic nerve sheath posterior. This is one of my friends who was attending one of our lectures on ultrasound of the eye. He was one of our faculty members, but said that he had never done an ultrasound of the eye. So he picked up the probe and did his own ultrasound with a projector in the back in front of the class. Quite delighted that it was so simple and so easy to learn. This just demonstrates the anatomy of the eye. The C is actually the eyelid with the cornea underneath. The A stands for anterior chamber. The P stands for pupil, or actually the lens right underneath the pupil, and the V is for vitreous, and the O at the bottom is the optic nerve or optic nerve sheath. This is an image taken from a journal article demonstrating the correct method for measuring the optic nerve sheath diameter. You draw a line down from the top of the optic nerve, 3 millimeters, and at 3 millimeters you draw a line perpendicular to that, measuring the optic nerve sheath diameter. That's where you take your measurement. This is the optic nerve sheath diameter on our patient. On the one side we have the diameter of a normal child, and you can see it measures about 4.1 millimeters. On the other side we have our patient, and she measured 5.7 millimeters, and it was bilaterally symmetrical. There's no general agreement on the exact measurements and what constitutes abnormal, but in generally we say that infants' optic nerve sheath diameter should be about 4, children should be 4.5 millimeters, and adults about 5.0 millimeters wide when we measure it 3 millimeters down and perpendicular. So in any case, this would be a widened optic nerve sheath for this young lady. Because of the ultrasound finding of a widened optic nerve sheath, we decided that this indeed was a worrisome headache and that we needed to work it up. We ordered a CT scan of her brain, which was read by the radiologist as within normal limits. We described to her and her family that she probably had a syndrome called pseudotumor cerebri, and that the best way to make a diagnosis of this was to do a lumbar puncture in the emergency department and measure her CSF pressure. Unfortunately, she refused the lumbar puncture. We consulted neurology, and they suggested that we go ahead and start acetazolamide as an outpatient, and they would follow her up in clinic in the next 1 to 2 weeks. Interestingly enough, 2 days later, she came back to the emergency department, and her chief complaint was, "I think I have pseudotumor cerebri, and I want a lumbar puncture." Unfortunately, at that visit, we were not able to obtain the lumbar puncture or the pressure, and she again was discharged on acetazolamide. Approximately 1 week later, she was followed up in neurology, and at that time her headache had completely resolved. Ultrasound saves the day again. Because the optic nerve sheath was enlarged at 5.7 millimeters, the patient got the appropriate workup and the appropriate follow-up and the appropriate treatment, and everybody was eventually happy. Before we go on to the next case, let me just mention that ultrasound of the eye can be used for multiple other things in the emergency department, not just measurement of the optic nerve sheath. We can actually look for foreign bodies in the cornea, the aqueous, or the vitreous. We can look for retinal detachment, which is the picture that we have down there before. You see the V shape at the bottom of the eye in the vitreous. That's basically a retinal detachment, which is still attached onto the optic nerve. We can look for a vitreous detachment. We can see hematomas or bleeds in the eye. We can see a lens detachment. And we've been doing a study recently to see if we can gain information on shunt evaluation in children with VP shunts to see if we can decrease the number of CT scans that these children receive.
This is a case of lower abdominal pain and constipation in a 6-year-old male with a chronic history of constipation. He has been to the doctor many times for this. He is on fruit and Miralax daily. He complains of lower abdominal pain for 3 days, with loss of appetite and no stool for about a week. On exam, his vital signs are normal, temperature is normal, physical exam is all normal except for moderately distended abdomen, good bowel sounds, and mild generalized tenderness to palpation over the abdomen.
Now, what can we do with this child with the ultrasound that would help us make a decision? What's our binary decision-making tree in this child? Well, we could do a rectal exam to see if there is fecal bolus or an impaction. We could also order an X-ray or flat plate of the abdomen to see if the colon or rectum is full of stool, but of course this involves ionizing radiation to the abdomen, and of course the rectal exam also is fairly invasive in a child and uncomfortable for the child, the parents, and the examining physician. Or we could do a point-of-care ultrasound. In our emergency department we have an ultrasound that we call the poop scan, and we actually shoot through the bladder into the rectum to see whether the rectal vault is distended or not. We also have an exam called the e-poop, or the extended poop exam, where you actually scan the descending colon to see if it's distended with fecal material. Of course, we decided to do the least painful, least invasive thing for this child, which was the poop exam, thus not exposing the child to a painful rectal exam or to ionizing radiation. This is the poop exam. On the one side, you can see a normal rectal vault on a normal child without an impaction, without distension. On the other side, you see our child. If you look at the red arrow, you'll see the red arrow points to a very large fecal bolus in the rectum that is quite distended and actually pushes on the bladder. So the point of care ultrasound actually gave us actionable information. We diagnosed this child as having a large fecal bolus or an impaction, diagnosed of course by physician performed point of care ultrasound. The child was given a Fleet's enema in the pediatric emergency department. According to his mother and the nurse, he had quite an impressive bowel movement. The child felt better. We avoided a rectal exam. We avoided radiation from doing a flat plate of the abdomen. The child and parents were discharged home happy. Doing a poop scan in the emergency department and giving an enema may not sound very academic or important to you, but believe me, sometimes simple things can make a big difference.
The next case is of a 13-year-old who presents with fever and sore throat for 4 days. He has pain on swallowing and a decreased appetite, but is maintaining his fluid intake. His mother has noted that his voice sounds muffled. This young man has otherwise been a healthy child. Vital signs today show a temperature of 38.6, a heart rate of 110, and other vital signs normal. He has bilateral tender cervical adenopathy, palatal petechiae, and bilaterally swollen tonsils, with the right greater than the left. There is exudate. There's moderate deviation of the uvula toward the left.
Okay, in this young man with tonsillitis, we really have a binary decision. If you look carefully at the picture, at the blue arrow, you can see that right tonsil is actually shoved over a little bit and pushing on the uvula toward the left side. So we have a couple of possibilities. We could call this tonsillitis. We could give him antibiotics based on the rapid strep results. If the strep is positive, we'll treat him with antibiotics. If it's negative, we'll call it viral and send him home with ibuprofen. And he can follow up with his primary care physician. Or the second option is we can call this peritonsillar abscess. And we have several options. We could do a CT to better define the abscess. We could attempt blind drainage in the pediatric emergency department using a needle. We could give him antibiotics and have him follow up with his primary care physician, or try to get an ENT consult today or tomorrow. Or, of course, the other option is we could do a point of care ultrasound at the bedside by the clinician. Now, you've listened enough to this video lecture that you know exactly what we will do. We chose option number 3, which is point of care ultrasound at the bedside by the clinician. We do this by taking an intracavitary probe and covering it with a probe cover. We come in to the tonsil from the opposite side, somewhat obliquely, and we look to see whether the tonsil is enlarged, whether it's cellulitic, or whether it has an abscess. Let me give you an idea of what we're looking for with that intracavitary probe against the tonsil. The normal tonsil is small, usually 10 to 20 millimeters. It's oval in shape and has a homogeneous low-level echo texture. We can also see peritonsillar cellulitis. The tonsils are enlarged, usually greater than 20 millimeters, and they're also homogeneous or have a striated appearance. But in this young man, what we're mostly interested in is whether or not he has a peritonsillar abscess. The tonsil should be enlarged, and it's usually heterogeneous and has a cystic lesion somewhere within the tonsil that may represent an abscess. Now, just to review, you can see on the one side we have a normal tonsil. It's oval and has a fairly homogeneous echo texture. The next slide over shows peritonsillar cellulitis with a little striated appearance or stranding. On the bottom, if you look carefully at the little red arrow, you'll see an area within the tonsil that is hypoechoic and represents an abscess. This is our child, and what you see is a little bit of an enlarged tonsil. It's fairly homogeneous, but there's a red arrow pointing toward a small hypoechoic cystic area that represents a small abscess. Now, this is an ultrasound of our same child, the same child we've been looking at, and I still have the intracavitary probe against his right tonsil, but this time I've turned on color flow, and that measures whether there's flow in and out of this hypodense cystic area within inside the tonsil. And as you can see, although there is unfortunately a little bit of flash artifact over the tonsil, there is no blood flow within that hypoechoic area. That makes this hypoechoic area almost certainly an abscess. This is not our child, but actually another child, and this child has a larger abscess, and I've included this so you can see what a larger abscess of the tonsil looks like on another patient. So what did we do with this child? What happened to our binary decision? Well, we saved him the cost and radiation of a CT scan. We didn't have to radiate his neck or his thyroid. And we didn't have to do a blind stick into that tonsil to see if there was an abscess or not. We were actually able to see that there was a small abscess on our clinician-performed bedside ultrasound. And what we demonstrated was that it was a very small peritonsillar abscess, too small to drain. In our institution, if the abscess is 1 centimeter or less, we generally treat it with antibiotics and follow up. If it's 2 centimeters or more, we drain it with a needle or have surgical drainage. If it's between 1 and 2, it's really dependent upon the attending physician's desires. This child was sent home on antibiotics to return for evaluation with repeat ultrasound the next day. However, the next day he was better and he was not rescanned as he was feeling much improved and actually had an uneventful course, and everybody was happy.
A mother brings in a 3-month-old boy. Her only complaint is his scrotal swelling. There has been no injury. She is not sure how long it has been, but thinks at least several days to a week or so. He has not had a fever. He is urinating well. He is in no discomfort, taking his formula well. He is not crying. It is Sunday morning at 8:30 a.m. There is no hospital sonographer available. His exam and vital signs are normal except for his scrotum. On exam, he has a large, swollen right hemiscrotum. It is not warm. It does not appear to be tender. The testicle is not felt on the right, but well felt on the left. There is no obvious hernia, and the penis is normal.
Well, what is our binary decision-making tree on this young man? Well, it certainly could be a urologic emergency. It could be a possible testicular torsion, at which point we have to call urology stat into the pediatric emergency department for evaluation. And most often they'll take these children immediately to the operating room to detorse and fix the testicle. On the other hand, maybe it's a non-urgent condition and the child can be followed up by urology clinic as an outpatient at the mother's and urology's convenience. Or what's the third option? Well, we could gather more information, of course, with a point-of-care clinician-performed ultrasound at the bedside. Of course, by now you could guess what we did. We performed a point-of-care bedside ultrasound. And this is this child's scrotum in his ultrasound. And what you see here is a testicle. There's a red arrow going to the testicle with actually quite good blood flow going through the testicle. And there's a large hydrocele. So this is a non-emergent urologic problem. The child can be discharged home and followed up by urology at the mother's and urology's convenience. The child has a normal testicle with excellent blood flow. It's a hydrocele. There's no evidence of torsion. Everybody's happy. Everybody goes home.
A 9-year-old was completing a jump on his BMX bike and was thrown over the handlebars. He had a helmet on and knee and elbow pads. He sustained a laceration to his chin, but there was no loss of consciousness and he had no other complaints. He was brought into the pediatric emergency department in full spinal immobilization, despite the fact that he had no other complaints. There was, however, the chin laceration, which needed suture repair. On physical exam, the patient's vital signs showed a blood pressure of 120/75, heart rate 105, respiratory rate 14. He was awake and alert, and in no acute distress. There was a large laceration to his chin that was open and bleeding. It measured about 2 by 1 centimeters. His spine was non-tender, heart and lungs were normal. There was a small contusion over the epigastric area that was mildly tender to palpation. The patient said he had hit the handlebars while going over them. Abdominal exam revealed normal bowel sounds. He was minimally tender throughout the exam. Extremities showed no abnormalities. Neurological exam was normal. Because of the mechanism of injury, the patient received C-spine films which were negative.
So here is our binary decision. Should we go ahead and suture that chin laceration, discharge the patient home, have him return to the pediatric emergency department if there are any problems? Or should we work up that bruise or abrasion on the epigastrium? Perhaps we should do a chest x-ray or a CT of the chest or CT of the abdomen, or admit him for further observation. Or perhaps we could gather more information by doing a point-of-care ultrasound fast exam in the pediatric emergency department. Before we go further, let me just explain what the FAST and the E-FAST exam is. The FAST stands for Focused Assessment with Sonography and Trauma, And the EFAST is the extended FAST exam, which includes an examination of the chest for pneumothorax or hemothorax and the paracolic gutters for retroperitoneal bleeding. The FAST exam is used as a rapid diagnostic entity for free intra-abdominal fluid, and in trauma patients, the free fluid is presumed to be blood. It's also part of the secondary survey in ATLS. The FAST exam has 4 views. It should be fast, in other words, it should be rapidly done. It should be systematic and thorough. The sensitivity of the FAST exam increases proportional to the amount of blood present. In other words, the more blood that's present in the abdomen, the easier the exam and the easier it is to see. Going through the FAST exam is really beyond the scope of this video lecture, but let me just say that the first step is to evaluate the right upper quadrant or Morrison's pouch for free fluid. You can see where the probe is put on the patient's abdomen, and below you can see a ultrasound evaluation of what a normal FAST looks like. In other words, there's no hypoechoic line or area between the kidney and the liver. Now this is the first part of the FAST exam on our child, the child that fell off the BMX bike, with a small contusion on his upper abdomen. You can see an arrow pointing toward Morrison's pouch, and within Morrison's pouch you see a hypoechoic area. This hypoechoic area represents free intraperitoneal blood in our child. Well, what happened to this child? Well, after the child had a positive FAST exam, we consulted pediatric surgery who elected to do a CT scan of the abdomen. That CT showed a laceration of the liver with a hematoma. They admitted the child to the hospital and managed him non-operatively, as they often do in children with liver lacerations that are hemodynamically stable. The child did well and was discharged home several days later. We avoided sending a child home with a laceration of the liver, and that's a good thing. The laceration of the chin was sutured in the emergency department. Everybody did well, and everybody was happy.
This is a case of fever and dysuria in a 3-year-old female who presents with her 3rd febrile UTI. The last one was 3 months ago. The bacteria was sensitive to several common antibiotics. She has not had symptoms until several days ago. She is eating and drinking, but less than usual. Her temperature is 38.9, heart rate 130, respiratory rate 16, blood pressure 120/70. Her physical exam is normal. She is non-toxic but looks uncomfortable. Urinalysis shows leukocytes and nitrites. She did not have a workup after the first 2 febrile UTIs.
So what are the possibilities here? Well, she could have a febrile UTI. Well, actually, she does have a febrile UTI. We could culture her urine, then treat her with oral antibiotics and send her home. We can have her follow up with her primary care physician for evaluation of her frequent UTIs. Or perhaps she has pyelonephritis, or a complicated febrile UTI with a renal abnormality, at which point we probably ought to start an IV, give her IV antibiotics, admit her to the hospital, and have urology or nephrology check her out in the next 24 hours to make sure she doesn't have a renal abnormality. Or, of course, we could do point-of-care ultrasound of her kidneys to evaluate her kidneys in the emergency department. If that cartoon is too small for you to read, it says, "No, I can't go out. I've got a big urinalysis test tomorrow." This is the ultrasound on our child, the one with the febrile UTI. The arrow points to the aorta, and this is an image of the right kidney. You're going to have to look pretty carefully at this, but one of the key features here is the kidney should not go over top the aorta. Again, this is the same child, the same image, and I still have marked the aorta, but this is a little clearer. So look very carefully again at that right kidney and look at the position of the aorta and tell me if you think that kidney goes over top the aorta and extends over the aorta to the left side. So what actually happened? How did the ultrasound help us with this child with a febrile UTI? Well, our ultrasound demonstrated a horseshoe kidney, thus this was not a simple febrile UTI, but a complicated febrile UTI, perhaps with upper tract infection. I called the pediatric nephrologist on call on the phone, and he recommended that the child get IV antibiotics in the emergency department, which we had already done. We also had obtained blood cultures and a urine culture. They gave us an appointment for the child to be seen in pediatric nephrology the very next morning, which was about 12 hours from the time we scanned the child. And the child presented and had a workup, which indeed demonstrated the renal abnormality, which we showed you on the original ultrasound. The child actually got better on antibiotics, was followed by nephrology, and everybody seemed to be happy, and ultrasound saved the day again. You can see at the bottom of this slide a little bit better picture of a horseshoe kidney where the kidney actually goes over the aorta in the transverse view of the abdomen.
This 15-year-old young lady comes to the pediatric emergency department complaining of amenorrhea for 2 to 3 months. She also complains of right lower quadrant pain and fullness. She describes no spotting, no discharge, no fever, no urinary symptoms. She admits to unprotected sex with her boyfriend, and also she admits to 1 episode of chlamydia in the past. She has no history of pregnancy in the past. Today, the exam is completely normal, including her vital signs. The abdominal exam is also normal. Urine dipstick is negative, and urine HCG is positive.
Hopefully by now you all are getting quite comfortable with this binary decision-making process in relation to point-of-care ultrasound. This patient has either one of 2 things. One is a condition which the patient can be discharged home safely. It is not a life-threatening condition, meaning that she has a normal early intrauterine pregnancy. The other is a life-threatening condition, meaning ectopic pregnancy, and you're going to need consultants and help in the emergency department tonight for that issue. Well, how can you decide between what is benign and what is life-threatening? At this point, you all ought to understand that we can do a clinician-performed bedside ultrasound. If the pregnancy is intrauterine, the patient can be safely discharged home. If we can't see a pregnancy in the uterus, then we must concern ourselves with the possibility of an ectopic pregnancy. Well, fortunately for this young woman, the transabdominal ultrasound demonstrates an intrauterine pregnancy. Within the uterus, you see a sac and you see a double decidual sign. And if you look hard, you can see a fetal pole. And if you look even harder and magnify the view as is here, you can see a heartbeat. So this young woman has an early intrauterine pregnancy and can be safely discharged home. An intrauterine pregnancy seen by ultrasound basically rules out life-threatening ectopic pregnancy. Now, this has not been meant to be a definitive talk about pediatric ultrasound. Many of the things you think about when you think about pediatric ultrasound, like intussusception or pyloric stenosis, or the exam for appendicitis, we haven't even mentioned. We haven't mentioned the important topics of starting lines in children and procedural skills, nor have we mentioned things like resuscitation and looking for pericardial effusion or cardiomyopathies. And we haven't even addressed things like musculoskeletal ultrasound. So there's a lot more that we could have discussed here, but we needed a place to begin, and I chose things that were simple and common to begin. I'm excited about this, and I hope after looking at this you can say to yourself, I think I can do this if I learn a little bit. Well, it's been a pleasure talking to you, and I hope tonight or today as you go and see your patient, you'll think about what you might be able to accomplish with clinician-performed bedside ultrasound. Thanks very much.